Certainly I'm where I'm supposed to be. In a molten sun, with you I am free. Today our hearts won first prize, 'cause we're wise with the feeling. Yeah, we're all we need.
Welcome back, guys. In the previous lecture, we did mitral valve prolapse and mitral regurgitation. So now we'll just move ahead with our mitral stenosis, which is very important by exam standards. Okay. So now we know that the most common rheumatic heart disease valvular lesion in children is MR, but in adults it's MS. What it basically means is that in children the the valve is freshly affected. Okay, so it will show regurgitation. But this stenosis, this takes time. So basically, when an adult has RSD for a very long period of time, then he will develop stenosis. Okay, so in any initial or acute lesion, you will have regurgitation, and in a chronic, long-standing lesion, you will have stenosis. So I hope this clears this up. So now, the normal valve surface area, okay, the cross-sectional area across the valve is 4 to 6 centimeters square. So based on this orificial area, we decide the severity of MS and also based on the length of the murmur that we'll discuss later. Okay, so we say it's severe MS when this area is less than 1.5 centimeters square. We say it's critical when it is less than 1 centimeter square. These two figures are very, very important. Okay, you can't forget this. All right, now during the diastasis period of the cardiac cycle, normally there is a free flow of blood into the ventricular cavity. Okay, but due to this disease, MS, this orifice is small now because of the stenosed valve. So lesser blood to left ventricle causes the turbulence. Okay, because of the narrow valve, and this turbulence causes a murmur. Okay, now this is very, very important. You have to understand the murmur of mitral stenosis. Okay, so we all know this is S1, this is S2, and this is S1. All right, between S1 and S2 is systole. Between S2 and S1 is diastole. All right, so we know that the filling of ventricle occurs in diastole. All right, so obviously the murmur will be in diastole. Okay, so diastole, well, like in the ventricular filling is divided into 3 phases. Okay, like I said, cardiac cycle is very, very important if you want to do well in CVS. Okay, so there is the first rapid filling. Okay, then there is diastasis, and then there is a last rapid filling. Okay, so what happens in the heart is when the pressure of the left atrium increases and the pressure of the ventricular sufficiently falls below the pressure of the atrium, there is an opening snap. Okay, this opening snap occurs when the mitral valve slightly opens, okay, and gives way due to the pressure gradient. Okay, so but now the thing is that the pressure generated because of this stenosed valve, the mitral valve, because of this stenosed mitral valve, the left atria is pretty big. It is enlarged. There is hypertrophy in the left atria. Because of that, there is increased pressure generated in the atria. So this opening snap will be very loud. Okay, so that's what it says here: loud opening snap. Okay, now because of this turbulent flow across the stenosed valve, you have a murmur. So, and since this murmur is occurring in the diastole and it peaks in the middle of the diastole, okay, so it is called a mid-diastolic murmur. Okay, but it begins from opening snap. So it's common sense, right? Unless the blood is not flowing across the valve, you can't have a murmur, and the blood starts flowing across the valve after opening snap only. Okay, so that's that. Now there is a, you can see there is a secondary peak in the valve. Okay, this peak is called pre-systolic accentuation. What does that mean? Okay, this means that this secondary peak corresponds with the last rapid filling stage. Okay, when the atria finally contracts really hard towards the end of the ventricular diastole to complete its last rapid fill. Okay, this causes this pre-systolic accentuation. Okay, so the final murmur of MS, if somebody asks you, it is mid-diastolic murmur with pre-systolic accentuation. This is something that you have to remember. If the question mentions this, you straight away go to MS. Okay, now this murmur, this is better heard when you are turned left. Okay, because the heart is closer to the chest wall. See, and this atrial systole, okay, this contributes to pre-systolic accentuation, like I said before. Okay, but let's say there is a condition where there is no atrial systole, something like atrial fibrillation, where the heart is vibrating as a closed chamber. All right, so in that case, there will be no atrial systole, so there will be no pre-systolic accentuation. Okay, now the severity of MS. Okay, like I said, it first of all it depends on the cross-sectional area of the orifice. Okay, but what it does not depend on is the loudness of S1. Okay, it does not depend on the loudness of P2. It does not depend on the intensity of the murmur. Okay, it is decided by the length of the murmur. Okay, why is that? Because once the pressure in the left atrium is increased tremendously, or let's say the disease has progressed far enough, so the pressure generated will be far greater, okay, as compared to when the disease was in its initial phases. So what will happen is the opening snap will start moving towards the S1. Okay, this opening snap, as the disease severity increases, this opening snap will start moving towards S2. Okay, so what this will do is that now this murmur then will start from here. Okay, so what has happened now? The length of the murmur has increased. Okay, so, and that is why we say that the severity of MS is dependent on the length of the murmur or inversely proportional to the distance between S2 and OS. All right. Now, as a part of the clinical features, we can see most of the features will be due to the pulmonary edema that is developing due to the left atrial enlargement. Okay, it will cause dyspnea on exertion. It will cause orthopnea. It will cause PND. Okay, it will cause left atrial enlargement. This left atrial enlargement can sometimes compress on the recurrent laryngeal nerve. It will lead to hoarse voice. This is very peculiar and it can be asked. Okay, this thing is called Ortner syndrome. Okay, please remember this. Not very commonly asked, but it can be asked. Now that, as you can see, the levels are increasing day by day. The competition is increasing, so you have to incorporate these kinds of points in your understanding of a topic. So now that I've told you before in previous lectures also, if there is any disease that causing left atrial enlargement, you can see atrial fibrillation. Okay, so this fibrillation will cause formation of clots. These clots can embolize, they can cause stroke and hemiplegia. Pulmonary arterial hypertension will cause exercise intolerance. All right. This is happening due to the back pressure changes. Okay, these back pressure changes will lead to pulmonary arterial hypertension. Okay, and this will lead to strain on the right ventricle. The right ventricle will start to fail. Right ventricular failure can occur. Okay, because due to this pulmonary arterial hypertension, this will lead to ankle edema. Okay, all the features of right-sided failure you can see in this. Okay, ankle edema, hepatomegaly, and all those things. All right. So, what happens when you examine the patient? When you examine the patient because of this enlargement of the heart, okay, there's a tapping apex beat. Okay, the S1 is loud. Why? Because the transvalvular gradient has increased. Okay, the left atrial pressure and the size is increasing. Left ventricular when the left ventricular pressure is low and there is excessive increase in the left atrial pressure, this S1 will be loud because of the increased gradient. There will be elastic recoil. There will be a soft S1. Okay, this is due to the calcification. All right, when the valve gets excessively calcified, it will become soft. All right, this is initial finding. Okay, don't confuse this. This is initial finding, and this is later on when the valve gets excessively calcified. So now the split in S1. Okay, the split in S1 is something that we can look at. Okay, what happens is we write S1 as M1 and T1. All right, the mitral side and the tricuspid side. Okay, so normally the mitral valve closes before the tricuspid valve. Okay, and that is why there is a split, physiological split. Okay, if it is less than 30 millisecond, it is normal. If it is more than 30 millisecond, it will be abnormal. So what happens is now, let me just show you this. So this is your M1 and this is your T1. Okay, on a scale, let's say this is time, M1 was occurring earlier and T1 was occurring later. But now, because of the stenosed valve, the same amount of blood will take more time to cross this valve. So this will start moving towards T1. And that's why we say there will be narrowing of the split. At some point, the M1 will coincide with T1. So that's when we will hear a single S1. And sometimes, even when the disease becomes more and more severe, you will find that the M1 shoots beyond T1. So then we'll hear a reverse split of S1, where we will hear T1 first and M1 later. All right. Now, when you look at S2, S2 is written as A2 and P2, aortic and the pulmonary component. Okay, S2 will be normal, right? Because the issue is not with those valves. The issue is with the mitral valve. All right, but because of this right-sided involvement of the heart and the left atrial involvement, if there is pulmonary arterial hypertension developing, then you can have loud P2. So it is not present in all the cases. Okay, only when PAH develops, then you will have loud P2. S3 will be absent. Why? Because S3 is a ventricular sound, ventricular gallop. All right. If you remember, I told you in the first lecture, please familiarize with yourself with S1, S2, S3, and S4. Okay. I'm sure you've done this in your physiology, that what heart sound corresponds to what. So S3 is a ventricular gallop. So the ventricle is not involved here. So S3 is absent. The murmur, as we said, MDM with PSA, that is mid-diastolic murmur with a presystolic accentuation in left lateral decubitus position. This is the best position to hear the valve of the murmur of mitral stenosis. Okay, now the workup. Always ECG in cardiology first. Okay, we'll see both P-mitral and P-pulmonale. This will depend on like in what stage of the disease you are in. All right. So left atrial enlargement. Of course, you will see these things: P-mitral and P-pulmonale. All right. Now, just X-ray. In just X-ray, you will see a straightened left heart border. Why? Because of the left atrial enlargement. You can also see the double atrial contour on the right side. Because of the left atrial enlargement, the right side will show a double atrial contour. All right. Now, if you the investigation of choice is transthoracic echocardiography. Echocardiography. Okay. When you do the echo, this is a very important sign which you see, which is a candle flame sign or hockey stick sign. All right. So I'll just show you here. This is the candle flame sign on echo. Okay. It confirms the diagnosis. Okay, it also quantifies because there is a Doppler associated, as you can see, multiple colors. Okay, so this is a Doppler associated with this. So it quantifies the stenosis also, and that is why this is the investigation of choice. All right. So this hockey stick sign, this is very commonly you will come across this in medicine. So where it is seen, hockey stick sign is seen in MRI, Creutzfeldt-Jakob disease. Okay, variant Creutzfeldt-Jakob disease. You'll also see in ECG in digoxin when you give digoxin. All right. Digoxin toxicity, you will see this. Also in MS, like we just did. So you need to treat severe MS. All right. So treatment of severe MS is percutaneous mitral balloon valvotomy, PMBV. As in short form, we say this PMBV. Okay. In this, what we do is we access the we access the basilic vein. Okay. From vein we go to atrium. Okay. Then we puncture the interventricular puncture the interatrial septum, and then we are in the left atrium, and then we are repairing our mitral valve. Okay. Very important question is, what are the contraindications to this PMBV? Okay. So these are any calcified severe mitral stenosis. Okay. It is contraindicated. Why? Because the risk of embolic stroke. Okay. The calcified valves are brittle. They'll break off and fly away. Okay. Now, if there is a severe MS plus MR, okay, in this it is contraindicated. Why? Because if you treat the MS and you try, it's a stenosed valve like this. Wait, let me show you. It's a stenosed valve like this, right? It's like this. What you are trying to achieve here is this. So what will happen now? The regurgitation will increase. Okay. So the MR will worsen. That is why in this combination we don't do this repair. Okay, we manage it in a different way. So if there is a severe MS plus left atrial appendage thrombi, okay, the same thing. If there is a thrombi here and you remove the stenosis, this will fly away to systemic circulation and cause lots of damage, stroke, hemiplegia, etc., etc. Okay. So this is all about your mitral stenosis. All right. Needless to say, before doing this, you have to familiarize yourself with ARF. Okay, acute rheumatic fever and rheumatic heart disease. Okay. Now we'll move on to the diseases of aortic valve. Yeah. Yeah. So as we know, aortic valve is a tricuspid valve. Okay. The damage to this valve can be due to senile calcification. Okay, or rheumatic heart disease also. Now, if the valve is faulty, so the opening and the closing both can be affected. So if the opening is affected, we call it aortic stenosis. If the closing is affected, we call it aortic regurgitation. All right. So the most common congenital valve disease is aortic stenosis. Okay. The most common congenital valve disease. Most common congenital heart disease is not aortic stenosis, it's VSD. Okay. So these are some important points. So let's start with AS first. Okay. Okay. So what is etiology? If it's a pediatric presentation, like in a child, you can see bicuspid aortic valve. It is the most common lesion in Turner syndrome. We have done this before. Okay. There can also be a unicuspid aortic valve, and always remember, of course, it's common sense that unicuspid will be more severe than bicuspid. Okay, the lesser number of cusps, more is the resistance, more is the stenosis. Now, in old age or senile patients, there can be calcification due to long-standing atherosclerosis and all those things. It is as a result of atherosclerosis of abdominal aorta. All right. Disease progression. When the disease progresses, there is differentiation of fibroblast or myofibroblast into osteoblast. Okay, this is what causes the calcification. Okay, and the balloon valvuloplasty is contraindicated in calcified valves. Again, we did this in MS also, that these calcified valves will break off and cause embolic phenomena. Okay, now as a result of rheumatic heart diseases, okay, there will be a commissural fusion. Okay, this valve, both valves will fuse, and therefore the flow across the valve will reduce. This is called stenosis. So the normal valve surface area is 2 to 3 centimeters square. Okay, you remember normal for mitral was 4 to 6. All right. So if this is less than 1 centimeter, it is severe. Okay, severe MS and severe AS. These two things you always should remember. Okay, they'll try to confuse you. All right. So please remember these things. Mediastinal radiation in Hodgkin's lymphoma and in breast cancer. Okay, so when you give radiation, what will it do to the valve? It will cause stenosis. Okay, there's something called Schoen complex. It is associated with pediatric aortic stenosis. Okay, what are the components of Schoen complex? This is an important question which can be asked to you in your central institutes. Okay, now there will be a parachute mitral valve. Okay, there will be a supravalvular mitral membrane. There will be a subvalvular aortic stenosis. Okay, the stenosis is below the valve here. All right, there will be a coarctation of aorta. Okay, now the common heart lesion seen in patients with Turner syndrome is bicuspid and more than aortic, more than coarctation. Okay, we have done this before. Okay, HOCM is associated with systolic anterior displacement of mitral valve, which we will do in HOCM separately. Now, clinical features. So aortic stenosis has a slight male predominance. Okay, but the bicuspid aortic valve, it is autosomal dominant. Okay, notch 1 gene is involved. Okay, in senile patients, hypertension and atherosclerosis can lead to AS. Okay, this is very, very important. A triad of AS. Anybody asks you what are the most common clinical features in AS, you will say SAD, SAD, syncope on exertion, angina, secondary to left ventricular hypertrophy, and dyspnea. All right, dyspnea is secondary to the increased left ventricular end diastolic pressure. So I don't think it needs explaining, but I'll just do it anyway. So these are your valves. This is your aorta. This is your left ventricle. So we are saying that this valve is stenosed. All right. So now this ventricle is pumping against increased resistance. All right. So that's why this leads to left ventricular hypertrophy. Hypertrophy will cause subendocardial ischemia, which will cause angina. Okay. And due to this increased in the pressure of ventricle, you will see back pressure changes in the lungs, which will cause dyspnea. Okay. Now, the left ventricular end diastolic pressure increases as a result of hypertrophy of left ventricle. This leads to increased left atrial pressure. This leads to congestion in lungs and pulmonary edema, and this will lead to dyspnea. Now, the examination findings of both AS and AR are very, very important. Okay, they can be asked to you as a single line MCQ also as a part of complete clinical question. Okay, so pulsus parvus et tardus. It's a slow rising pulse with delayed peak. Okay, I'll just show you the pulse. Just let me see. Yeah, yeah. This one. This is pulsus parvus et tardus. Okay, what does this mean? It means a slow rising pulse. Okay, it has a small or no dicrotic notch. So you can also call it as a anacrotic pulse. All right, so this is it. So what happens is, due to the stenosed valve, there is a decreased flow of the blood. So it's a slowly rising initially when the ventricle contracts, there is a rapid rise in, and then there is a slowly rising pulse. Why? Because it's stenosis valve. All right. So this is called, and then it comes down. So that's why it's called pulsus parvus et tardus. All right. I hope it's clear. Yeah. So as we discussed earlier, in severe AS, the aortic valve area is less than 1 centimeter square. Okay. So due to this, left ventricle has very high pressure. Okay. And when the blood from left ventricle passes via stenosed aortic valve, there is very much increased turbulence in the blood flow. The volume of blood going from left ventricular to aorta is decreased. Okay. But the velocity of blood flow is obviously increased because it is being pumped against a stenosed valve. The apex beat will always be displaced because increased size of left ventricle. All right. So it will cause a double apical impulse. Okay. Secondary to the hypertrophy of left ventricle. This character of this beat is called heaving. Okay. The impulse hits your finger and lifts it up. This is called heaving. This displacement is to the left side, of course, and felt in fifth and sixth intercostal space as it is double apical impulse. All right. This is very important. So now we come to heart sounds. S2. S2 will be narrow split. Why? You see, as I told you before, these are the components of the heart sound. Okay, and we write it as A2 and P2, suggesting that A2 closes first, P2 closes later. But now because of this stenosis, A2 will start shifting towards P2. Okay, so there will be narrowing at first. Then you will have a single S2, and then A2 can go beyond P2 also. So there will be a reverse split, as we had done in MS. All right. So that's what this says here. That narrow split, paradoxical split, and single S2, all these are possibilities. Okay. S4 will always be present. Well, not always, depending on how advanced the disease is, S4 will be seen in this disease. Why? Because S4 is a ventricular, S4 is a atrial sound. Okay, remember S3 is ventricular. Okay, and S4 is atrial. So now because the ventricular is enlarged, of course the atria will have to contract more fiercely. So that's why you will have a atrial sound, and that is why S4 is present. See, as it says here, compensatory left atrial hypertrophy. Left atria generate more pressure to propel blood into the ventricle. So S4 is produced. S4 is a atrial sound. This is very important. All right. If this patient of AS goes into heart failure, then S3 can also be present. Yeah, because I told you S3 is a ventricular sound. Ventricular sound. So when there is left ventricular failure, you will get this as well, S3. Okay. But however, initially S3 will not be present. Only S4 will be there. The murmur, ejection systolic murmur. Yeah, because we had discussed this. Where? In MVP. Okay. There also in MVP, what kind of murmur was there? It was late systolic. Okay. Late systolic starting from mid systolic clicks. All right. But here it is ejection systolic. It will start from S1. The moment ejection starts, the murmur starts. Okay. It will go up and down, crescendo, decrescendo, ESM murmur. Okay. S4 also present. All right. So the murmur of AS radiates to carotid artery. So it is known as carotid thrill. Okay. The murmur of MR. Okay. Just a comparison. The murmur of MR, if the posteromedial leaflet is involved, it goes to the radiates to the base of the heart. And if it is involving the anterolateral leaflet, it radiates to the axilla. Okay. And this radiation is also seen in MVP. How to differentiate between these two? We have done this in MVP. Okay. Now, vibrations of valvular cusps when blood passes from aortic annulus leads to murmur to radiate into axilla. This is known as the Gallawardine phenomena. This radiation into axilla can lead to confusion of aortic stenosis with mitral regurgitation, as murmur of mitral regurgitation also radiates in axilla, as we have seen here. All right. This is called the Gallawardine phenomena. This is very important. Okay. Now we come to the workup. In the workup, we'll do the ECG, of course. Okay. Signs of LVH. I'm sure these things have been taught to you in the lecture for ECG, but I'll just go over them very quickly. Okay. So signs of LVH, the size of S wave in V1 and R wave in V5 or V6. If you add them, it will be more than 35 mm. Okay, you can also see a strain pattern. Okay, basically when there is left ventricular hypertrophy, so you will see a strain pattern which is T inversion in V5 and V6. All right, now chest X-ray, there will be increased CT ratio, of course. Now for echo you have to demonstrate the valvular morphology. Okay, so you do the classification. Mild is when 1.5 less than 1.5, moderate less than 1 centimeter square, between 1.5 and 1, and less than 1 is severe. Okay, investigation of choice to see any valvular calci. So calcification you want to see anywhere in body, always answer. If you don't remember what is the answer and the question specifically mentions calcification and you're not sure and CT chest is in the option, please mark CT chest. Okay, and now for coronary angiography should also be done in patients of aortic stenosis, as most of the patients are of old age. Geriatric population and atherosclerosis is very common in these old age patients. Treadmill test and dobutamine stress echo are not done in these patients with severe aortic stenosis. Yeah, because there is severe compromise, decrease in left ventricular ejection fraction because of the stenosed valve. Okay, so death in patients of aortic stenosis. If syncope or angina is present as a symptom, death is within 3 years. Okay, if dyspnea is present as a symptom, death is within 2 years. Okay, so basically you remember dyspnea is equal to DO. Okay, easier to remember. If congestive heart failure is present, death is in less than 2 years. Okay, 1.5 to 2 years. So highest chances of death seen in patients with congestive heart failure. This is very important. Please remember this. Now we come to the treatment part. So we divide in 4 grades. Okay, in grade A there is no narrowing, but risk factors are present. In grade B there is mild narrowing, mild to moderate aortic stenosis. In grade C it's severe but it's asymptomatic. And in grade D it's severe and it is symptomatic. Okay. So in severe aortic stenosis, we have a special definition for this, and this can be given to you as a multiple correct answer question. So if the transvalvular gradient is more than 40, okay, what is this? This is the pressure difference between left ventricular and aorta. All right. If it is more than 40, if the ejection velocity more than 4 meter per second, okay, that is the 4 times the normal. So normal is 1 meter per second. All right. Size of the orifice is less than 1 centimeter square. Okay. Then this is called severe. Okay. So more than 40, more than 4, less than 1. Please remember this. Very important. Now treatment. Stage D. What is stage D? Severe and symptomatic. So we do a transcatheter aortic valve replacement. Okay. As you can remember in MR, we had told you that we do a mitral valve repair and not a replacement, because then we have to give warfarin lifelong. But here we do valve replacement. Stage C. What is stage C? It is symptomatic, severe and asymptomatic. So this patient has concomitant risk factors like triple vessel disease, left ventricular ejection fraction less than 50%. In these conditions, treatment is given again transcatheter aortic valve replacement. Statins are given to prevent further progression of atherosclerosis and thus triple vessel disease, and statins doesn't prevent further calcification. Okay, so statins have no effect on calcification.